members and delegates to the Masterclass on Conference to Clinic 2024 Breast Cancer. Now, it is my pleasure to invite our Program Director, Dr. Ashok Kumar Vaid, sir. He is a chairman in the Department of Medical Oncology and Hematology, Medanta, the Med City, Gurugram. Over to you, sir.
Good evening, friends. It's a proud moment for us to bring to you the latest in breast cancer, both in the space of early as well as metastatic breast cancer. What has happened recently in the major conferences, particularly the ASCO 2024. And through the next one and a half hours, we would be dwelling on the key trials which were presented. And at the end of it, we would have a panel discussion. The next slide to show the program. So to have a panel discussion where many more aspects of management of breast cancer would be dissected. Dr. Sachin is speaking on early breast cancer, newer studies, and Dr. Jehan Dabar is speaking on advanced breast cancer, new studies, and the panel discussion would be moderated by Dr. Chandrakant. I thank all the faculties. I thank all the panelists for taking time out. And we have more than 360 joinees from at least about 16 countries apart from India who have joined this program and who have registered for this program, which is a great sort of an encouragement to us. And that's what keeps us going from month to month. I extend my gratitude and my thanks to Om Mishra from Samarth Pharmaceuticals. The big thing and the great thing is that we don't discuss their products in any of these master classes. Om, I'm really indebted to you for that, for not pushing the commercial agenda, but pushing the science. And that's what excites us in this collaboration with you and your esteemed organization. I thank Rajesh, Priyanshi, Anshika, and the entire team at Ideas for creating this platform, for propagating this platform all across the world. That is why we have joinees from many more countries. With that, and without any further ado, and without taking more time, I would, I think Dr. Shyam Agarwal has not been able to join.
I've joined.
Sir, you missed my call. That's why
I have
the privilege of briefly introducing Dr. Shyam Agarwal, a friend and a mentor. I was senior to me at Adyar. Lot of learning, being a senior, and those were the days when there was no internet. Everything was in the printed format, and a lot of good things would be passed on from generation to generation, and that's how the education, the learning used to happen. He's the director, Navodaya Cancer Hospital, Bhopal. Over to you, sir, and a very warm welcome to the meeting.
Thank you. Am I audible?
Very well.
Yeah, thank you, Dr. Ashok. I'm really very deeply emotional to see you after a long time on such a masterclass and webinar of a great repute. And you rightly said that has been attended by many of the oncologists all over the world. And since last many months also, I am also regularly attending your masterclass, and it is really wonderful to chair this particular session with you. So thank you very much, Dr. Ashok, and I really indebted to you having this particular conference and asking me to chair this session. Now, this the whole program has been briefed by Dr. Ashok already, and there's new studies with the post-ASCO have been going to be discussed. The early breast cancers, newer studies, as well as the advanced stage. So, not taking much of time, I've got this slide of starting the early breast cancer newer study by Dr. Sachin Gupta. So, hand over to Dr. Sachin. Go ahead, and we'll be talking in between. Thank you.
Thank you, Dr. Vaid, and thank you, Dr. Shyam Agarwal, for organizing these wonderful meetings. And so without taking more time, I would share my screen now. My slides are visible.
Yeah. You have to make it on the
Slideshow.
PowerPoint
Yeah.
mode. Yeah.
Yeah.
Okay,
Right.
that's fine. Thank you.
So as already Dr. Veda set the stage, and so we are discussing some newer, exciting abstracts which were presented in ASCO this year. And so just starting with first abstract. So this is I-SPY 2.2. This is about neoadjuvant Dato-DXd plus durvalumab in high-risk stage 2 and 3 HER2 negative breast cancer. And so this was a multi-center open-label adaptive phase 2 platform trial. So this is some novel idea which has been thrown. Now, what they have done is they did genomic profiling via 70 gene assay for stage 2, 3 HER2 negative high-risk breast cancer patients, and started with, so this Dato-DXd is a ADC. So this is basically anti-TROP2 topoisomerase 1 inhibitor ADC. Now this is combined with immunotherapy durvalumab, and so they give 4 cycles of this treatment, and then there is predictive residual cancer burden. So this is being assessed by MRIs and biopsies after every few cycles, so roughly 4 cycles. And then if they get good response, or let's say a CR, then they proceed with surgery. And if they don't, then the patient gets on to next set of treatment, which is standard of care for that particular profile. And so there are some response predictive subtypes which they have defined, and standard of care treatment with chemotherapy plus minus immunotherapy, and so AC regimen and PDL1 inhibitor. So all this is done subsequently. And the primary endpoint is to look after the pathological CR. So now is the slide moving for you?
Now it's moved.
Yeah. So now the efficacy of this neoadjuvant datopotamab DXd plus durvalumab. So on the left side, we see the response predictive subtype. So they have divided the number of patients into whether they are hormone receptor positive, immune response negative, and DRD negative. So DRD is again another parameter which they have included in this. So into 4 subtypes they have divided: HR positive, immune negative, DRD negative, or all 3 negative, or immune positive, or immune negative, DRD positive. So these are the number of patients: 25, 23, 47, 11. Now, if you look at this pathological CR thing, so in the immune positive subgroup, there the pathological CR is the highest. And out of these patients, if we see by receptor subtype in the hormone receptor positive and hormone receptor negative wise, so 64 patients were HR negative, and the maximum pathological CR was seen in HR negative patients. So which suggests that the effectiveness is amongst patients who are immune response positive. So this was the safety data, where the usage of ADC plus durvalumab. So there was some nausea, stomatitis, fatigue, rash, constipation, alopecia, ocular events, headache, cough, and decreased appetite. And on the right side, we have immune-related adverse events, which we commonly see as rash, pruritus, adrenal insufficiency, pneumonitis, hypothyroidism, colitis, hepatitis. But if we see, the grade 3 and 4 events were not too much, and it was fairly well tolerated. There was one fatal adverse event, grade 5 cardiac arrest in block B in a 70-year-old patient who had hypertension. And one reported case of ILD was seen in the group. So to conclude, this trial suggested that in patients with high-risk stage 2-3 breast cancer, neoadjuvant ADC plus durvalumab resulted in pathological CR of 33% overall, allowing them to proceed straight to surgery without giving, chemotherapy as we do. And model pathological CR with this combination was highest for patients who were immune positive response, according to the algorithm they chose from the 70 gene assay, there were no new safety signals and no apparent increase of ILD with addition of this. And the investigators noted that additional information about entire treatment sequence will be reported in future. So there are more data will be seen subsequently. So this is an exciting new way of treating patients, and maybe the genetic assay would suggest in which patients we choose such a combination of ADC along with immunotherapy. So ADCs are going to be more, used in coming years. And so coming to the next abstract. So this is a brief. So this is adjuvant avelumab versus observation. So this is again high risk early TNBC post neoadjuvant or adjuvant chemotherapy, open label randomized phase 3, and median follow up is about 52 months. And stratification by adjuvant therapy and number of nodes, T size, or post neoadjuvant patients, residual disease versus not. So adults with the high risk TNBC were included, and so what they did was, after completion of the whole treatment, they give avelumab 10 milligram per kg 2 weekly for 1 year versus observation. And the co-primary endpoints were DFS and DFS in post-neoadjuvant population, and secondary endpoints were OS, DFS in PDL1 positive patients, and safety. So if we look at the DFS and OS here, so 3-year DFS 68 versus 63, difference is about 5.1 with hazard ratio of 0.81. And 3-year OS, the difference is about 8.5, and 3-year distant disease-free survival, the difference is 7.5. So the hazard ratio are modest, and if we see the 3-year OS HR, that is 0.66 with a p-value of 0.035. And in post neoadjuvant population, again there is a good difference seen of 6.2 with a hazard ratio of 0.8. And safety wise, the adverse events were similar as we usually encounter when we are using immunotherapy agents. And I won't go deep into this right now. So to conclude, in patients with high-risk TNBC, avelumab provided non-significant improvement in 3-year DFS, but significantly improved the 3-year OS and DDFS in intention to treat population versus observation. And so 3-year DFS was a hazard ratio 0.81, and for neoadjuvant population 0.8, 3-year OS the HR of 0.66, and DDFS the HR of 0.7. And 72% of patients completed this treatment with avelumab, which was well tolerated. And so they concluded that avelumab could have a role in treating patients with early high-risk TNBC breast cancer. So this is again a novel way of adding immunotherapy, and a reasonably good difference in 3-year OS has been seen here. Coming to the third abstract. So this is another data from RxPonder, this subset analysis, where serum AMH, so this AMH is anti-Mullerian hormone, and adjuvant chemotherapy for premenopausal patients with, so now we are talking about HR positive, HER2 negative early breast cancer patients here. So adults with this subgroup, 1 to 3 positive lymph nodes without distant mets, who received adjuvant taxanes plus minus anthracyclines chemotherapy, and recurrence score 0 to 25. So this patient received chemotherapy followed by endocrine therapy or endocrine therapy alone. Now all these characteristics, my slides are again stuck, I think. Okay. So if we see this subset analysis, IDFS by menopausal status. So this graph is for premenopausal. No significant IDFS difference was seen for postmenopausal women, right? And subset analysis found less IDFS benefit in premenopausal women who were more than 50 years. And if the serum AMH and inhibin B were low. So these were good markers for diminished ovarian reserve. And current analysis assessed benefit with chemotherapy in patients who were less than 55 years of age using all these serum markers of ovarian function. So 1700 patients, and they did all the serum markers of estradiol, FSH, LH, AMH, and found premenopausal nearly 1032 patients, and about 1016 patients were included in the analysis here. Now, if we look at this, now serum AMH has been defined as, so the units are picogram per ml, and less than 10 is the cutoff where they consider it to be low, and the patient is practically postmenopausal if this is low. And when they saw this according to age, they found that in the age 50 to 54, nearly more than 50% patients were having low AMH. And of course, with less age, the chances of getting low AMH and being postmenopausal were less. So nearly 21% of premenopausal women less than 55 had serum AMH in postmenopausal range. So nearly 1/5 patients were being considered as premenopausal, whereas they were actually postmenopausal according to the ovarian function depending upon AMH level. Okay, so now they saw that pre-treatment serum AMH, it predicts chemotherapy benefit in premenopausal women less than 55. So if we look at these, the figures between these bars, so AMH less than 10, the chemo IDFS benefit 0.019. So here some significance was achieved. Whereas for estradiol, progesterone, FSH, these things there was no significant difference seen. So what they concluded was that premenopausal less than 55 with low AMH, they have no IDFS benefit with chemotherapy. So they are as good as postmenopausal, and so being postmenopausal, they don't benefit from additional chemotherapy in this group. Whereas patients with high AMH or medium AMH, there was 7.8% improvement in 5-year IDFS with chemo. So traditionally, we have been using, at least I have been using LH-FSH estradiol and not actually using AMH for making treatment decisions. So this could be one good data to include AMH also in the algorithm. So here, premenopausal less than 55 with low AMH have no distant relapse-free survival benefit with chemotherapy. So for the low AMH, the curves are almost identical. And for medium high AMH, there is difference. So additional benefit with chemotherapy is there. So to conclude, among self-reported premenopausal patients less than 55 with baseline AMH levels more than 10, they would show benefit from chemotherapy followed by hormonal therapy compared to AMH levels less than 10. So this is a better indicator of chemotherapy benefit than self-reported menopausal status or estradiol LH FSH levels. So this AMH-based selections may be good. It may inform who most benefits from addition of adjuvant chemotherapy. I think that makes some good sense of using this particular test. And coming to the last abstract. So this is about Natalie trial. So this is a subgroup analysis of adjuvant ribociclib with the AIs versus AIs alone in patients with stage 2-3 node negative hormone receptor positive EBC. So this is about node negative, right? So recurrence risk for patients with stage 2-3 hormone receptor positive EBC persist after adjuvant endocrine therapy, irrespective of nodal involvement, and 40% patients with ER positive breast cancer had N0 disease. And for 22% of these individuals, disease recurred in few years. And so we already know that Natalie trial reported statistically significant improvement in invasive disease-free survival for patients with stage 2 and 3 hormone receptor positive EBC, including node N0 disease, right? So when we combine ribociclib with NSAIs, and so the hazard ratio here was 0.749. And so now this analysis would be for node negative subgroup. So this is the trial we know. Ribociclib in the dose of 400 mg was given for 3 years, and NSAIs were continued for 5 or more years. Now this is the N0 subgroup. If we look at this N0 subgroup, the median age is 55. Stage 2A patients were nearly 74%. Grade 2 were 49. So according to KI 67 also the stratification they have done. And about 104 patients were grade 3 and stage 3 were 25. So they have also stratified according to the T status. We are nearly, so majority patients if we see are about T2 and T3 here, and about 9% patients were T4 disease, and majority patients are grade 2 or grade 3 here. So now this is the IDFS in N0 subgroup. If we look at 3-year IDFS, 93.2 versus 90.6%. And so distant disease-free survival and distant relapse-free survival, if we look at these data here, 3-year 94.3 versus 91, 96 versus 92. So about 3 to 4% difference here, with hazard difference, hazard ratio 0.7 and 0.58 here. And so these are the safety data, which is similar to what we usually see with the addition of ribociclib. And so if we come to the conclusions here, so this phase 3 analysis, so this showed improved efficacy of addition of ribociclib, and 3-year IDFS 93.2 versus 90.6 with hazard ratio of 0.723. So the DDFS and DRFS benefit were consistent with IDFS, and so this 3-year rates among control group highlight unmet need and risk of recurrence for N0 disease treated with endocrine therapy alone. And safety profile, as we have seen, was similar to what we have seen for the whole NATALI intention to treat population. So the investigators concluded that this addition of ribociclib can lower recurrence risk with tolerable safety for specific patient with stage 2-3 node negative HR positive EBC also. So this is all I have in the presentation here. Maybe we can have some discussion now, or maybe later in panel discussion as you.
I think we'll have in the panel discussion. Thank you, Dr. Sachin, and now I invite Dr. Jehan Dhabar from Mumbai to go ahead with the presentation of advanced cancer, breast cancer studies. Dr. Jehan Dhabar, please.
Thank you, sir, for the kind words.
Yeah, thank you.
I'll just share my screen. Is my screen visible?
Yes, yeah.
Okay.
Very good. Yeah.
So, good evening, everyone. I'm thankful to Dr. Ashok Vaid, sir, and Dr. Agarwal, sir, for giving me this opportunity. So today I'll be talking upon the key takeaways from ASCO 24, the key abstracts, which were really interesting. I feel, are going to be potentially game-changing in the future. And these will be primarily on advanced breast cancer, as Dr. Sachin has already covered the early breast cancer ones. So coming to the Destiny Breast 06 trial, where we use trastuzumab deruxtecan. Just one second, let me just hide the control center. So it was a Destiny Breast 06 where trastuzumab deruxtecan was compared with chemotherapy in previously treated hormone receptor positive, HER2 low or HER2 ultra low metastatic breast cancer. So this is a new subgroup that is emerging, and even in my day-to-day practice, when patients are progressing on our routine regimens, and I have to go back and literally look at the histopath reports, what was their HER2? Was it 1 plus? Was it 2 plus? Because as a matter of habit, we used to write HER2 negative for even for HER2 2 plus back a year or 2 years back. So now it's very important that we look at the HER2 score. Is it 1 plus? Is it 2 plus? And not just positive or negative. So in a Destiny Breast 06, so patients who are hormone receptor positive metastatic breast cancer with progressive disease on at least 2 previous endocrine therapies, with or without a targeted therapy, and no prior chemotherapy, and who were HER2 low, that was IHC 1 plus or IHC 2 plus but FISH negative, or HER2 ultra low, that is IHC more than 0 or less than 1 plus, and this is based on the IHC assessment using the most recent evaluable IHC sample by the pathologist. So these patients were then randomized to trastuzumab deruxtecan to either 5.4 mg per kg 3 weekly, or versus the chemotherapy of physician choice, which could either be capecitabine, paclitaxel, or nab-pacli. So if you look at the the prior treatment, what patients had already received in the HER2 low subgroup, the number of endocrine therapy lines that were already seen, that around 62% patients had already received more than or equal to 3 endocrine therapy lines in the trastuzumab deruxtecan arm. And if you look at the chemotherapy arm, 49% patients had received some form of endocrine therapy that is more than 3 lines. In the HER2 ultra low, also 13% patients had received more than 3 endocrine therapy lines, and in chemotherapy 9% patients had received more than 3 endocrine therapy lines. In my clinical practice, patients means beyond 2 lines or third line endocrine therapy, most of my patients end up on chemotherapy. So let us look at what prior endocrine therapy they had received. So either a monotherapy, which was they received either a CDK4/6 or some other targeted therapy. So coming to the efficacy in the Destiny Breast 06. So if you look at the HER2 low population, the median PFS by blinded independent central review was around 13.2 months in the trastuzumab deruxtecan arm versus only 8 months in the chemotherapy arm. And the 12-month OS rates were 87% versus 81% in the chemotherapy arm. And also this, we should take into consideration that the patients who progressed in the chemo arm had switched over to trastuzumab deruxtecan as well. If you look at the HER2 ultra low population, the median PFS was around 13.2 months in the trastuzumab deruxtecan versus 8.3 months in the chemotherapy arm. So I think this particular subgroup is very interesting because we can get more and more patients who can be eligible for trastuzumab deruxtecan. So now we have one more drug to treat this disease. So in this particular subgroup. So let us look at the anti-tumor activity. The confirmed overall response rates for the HER2 low population for trastuzumab deruxtecan was around 56% versus 30% for chemotherapy. And for HER2 ultra low, the response rates were something around 60% versus only 26% in chemotherapy arm. Complete response rates were seen around 2.5% patients in HER2 low, and no patient in the chemotherapy arm had a complete response. And in the ultra low setting, around 4% had a complete response and 0 patients had a complete response in the chemotherapy arm. The median duration of response that we saw was around 14 months in HER2 low subgroup for trastuzumab deruxtecan versus only 8.6 months in the chemo arm. If you look at the HER2 ultra low arm, 14 months again versus 14 months in the chemotherapy arm as well. In all comers, if we see the trastuzumab deruxtecan, the duration of treatment was 14.3 versus 8.6. So coming to adverse events and adverse events of special interest. So whenever we talk about trastuzumab deruxtecan, the first thing that comes to our mind is pneumonitis. So of course, the grade of pneumonitis, all patients in the trastuzumab deruxtecan arm, pneumonitis was seen significantly higher as compared to the chemotherapy arm. That is bound to happen. And this is a known adverse event with transdermal deruxtecan. I have used transdermal deruxtecan so far in around 5 to 6 patients, and thankfully, I haven't seen any ILD events. So if you look at the ILD events, 49% patients had ILD, some form of ILD, and majority were grade 1 in the transdermal deruxtecan, and only 1% had ILD in the chemotherapy arm. Coming to another adverse event which always comes to mind with any anti-HER2 therapy, that is left ventricular dysfunction. So a decrease in the EF was seen in 35% patients in transdermal deruxtecan versus 12%. Again, majority of these patients were in a grade 1, grade 2 drop in EF. The other side effects which were seen across both arms and slightly more in the transdermal deruxtecan arm was nausea, fatigue, alopecia, neutropenia, anemia, and decreased appetite. So the next trial that also is a very interesting trial because patients progressing on a CDK4/6 with AI in our practice is something like an end of a honeymoon, I would say. So all our hormone receptor positive MBCs, my first line therapy, of course, and for most of us is AI with CDK4/6 inhibitors, and we have excellent response rate, excellent disease control, but patients progressing on this combination, everything else after that seems to fall short. So I think the post-MONARCH is something that may be useful in this subgroup. So it was a global double-blind placebo-controlled phase 3 trial where we had hormone receptor positive, HER2 negative metastatic breast cancer patients who had a progressive disease on first-line CDK4/6 with an AI for advanced disease or a recurrence disease on or after a CDK4/6 with endocrine therapy in the adjuvant setting as well. So these patients were stratified by the geographic region, visceral mets, and the prior CDK4/6 treatment duration. So these patients were then randomized to abemaciclib with fulvestrant or placebo with fulvestrant. So it's very important that we look at what kind of prior treatment these patients receive in this trial. So in the setting of prior CDK4/6 therapy, all the patients almost in the abema and fulvestrant arm had an advanced disease. We had no patients in the prior adjuvant treatment arm, and 2% patients had some adjuvant treatment, prior adjuvant treatment, the placebo and fulvestrant arm. What type of prior CDK4/6 therapy? So most of the bulk of the patients were on palbociclib, and after that it was ribociclib, and only 8% patients had received prior abemaciclib. And coming to the duration of prior CDK4/6 inhibitors, so almost 70% patients in both arms had more than 12 months or recurrence after adjuvant therapy, and less than the prior CDK4/6 therapy was less than 12 months in around 25 to 30% patients. So let's look at the PFS benefit. So if you look at the investigator assessed PFS benefit at 6 months, the PFS rate was 50% versus 37% for abemaciclib fulvestrant and the placebo with fulvestrant arm. And a blinded independent central review PFS was 68% versus 45%. So it is important to see which subgroups did better. So if we look at the patients who had received a CDK4/6 for more than 12 months or who had recurrence after adjuvant therapy, the PFS was 7 months versus 5.4 months. And in patients who had less than 12 months of CDK4/6 therapy, the PFS was 5.5 versus 3. So this subgroup is, of course, something like a hormone resistant subgroup. So we obviously had low PFS rates. Looking at the visceral mets, so when patients had Visceral mets, the PFS is for 5 months versus 3.7 months, and without visceral mets, it was 11 months versus 5 months. The the PFS based on ESR1 mutation and the PIK3 mutation is not yet reported and it is awaited. So coming to the adverse events, of course, the adverse events was marginally higher in the Abema and fulvestrant arm. Diarrhea was significantly more as compared to placebo fulvestrant. Neutropenia, anemia was more seen in the Abema and fulvestrant arm. Abdominal pain, thrombocytopenia. These are the class-specific side effects that we see with Abema. And in my clinical practice, Abema with appropriate dose modifications is, I feel, manageable. So coming to the next trial that we see, that is the SACI-IO, that is sacituzumab with IO in hormone receptor positive patients. So this was the phase 2 data of sacituzumab govitecan with pembrolizumab in hormone receptor positive HER2 negative metastatic breast cancer. It was a phase 2 multi-center randomized trial in this patients with hormone receptor positive HER2 negative locally advanced or metastatic breast cancer who had received more than one prior endocrine therapy for their disease or had progression less than 12 months from adjuvant endocrine therapy, less than one prior chemotherapy for metastatic breast cancer, and no prior topoisomerase 1 inhibitor ADC or irinotecan, and no prior exposure to any PD or PDL1 inhibitor, and no active brain mets. So these patients were randomized to sacituzumab govitecan with pembro or only sacituzumab govitecan. And sacituzumab was given at 10 mg per kg day 1, day 8 of a 21-day cycle, and Keytruda was dosed at our standard dosing of 200 mg every 3 weekly. So in the PFS benefit and the intention to treat population, which was a primary endpoint, there was a trend towards, I would say, a better PFS in the sacituzumab with pembro arm of 8 months versus 6 months in the sacituzumab only arm. The hazard ratio was 0.8 and the p-value was 0.37. So not so significant, but definitely it was showing a trend towards a better PFS. Let us look at the PFS by PDL1 status. Of course, this would make some more sense. So in patients with a CPS more than 1 or PDL1 CPS more than 1, the median PFS was 11 months versus 6 months in only sacituzumab. And if we look at the CPS less than 1, the negative subgroup, the PFS was more or less similar at 5 months. Coming to the adverse events that we see, the overall safety profile for sacituzumab and pembro versus sacituzumab alone, we saw 98% versus 96% treatment-related adverse events. And the common adverse events that we saw was decreased neutrophil count in 69% patients in the sacituzumab with pembro arm versus 59% in only the sacituzumab arm. Anemia versus low WBC, diarrhea were some of the adverse events of concern. Coming to the next trial, which is Destiny Breast 07. So the reason why this trial was included, because again, this is another potentially game-changing trial where we can head towards a chemotherapy-free regimen in de novo MBC. So I think that is where things are going now. So we're trying to move towards a chemotherapy-free regimen in most diseases. So this was, we all know that transfer deruxtecan has been a game changer for HER2 positive breast cancer. And topoisomerase 1 inhibitor, the payload that we see, it is approved as a monotherapy for adults with unresectable metastatic HER2 cancer who have received prior anti-HER2 therapy. So Destiny Breast 01 is a phase 1b, phase 2 study that is investigating the safety and efficacy of transfer deruxtecan as monotherapy and in combination with other agents for HER2 positive MBC without prior treatment, of course, in the metastatic setting. So the current report only includes data from interim analysis of transfer deruxtecan alone or in combination with pertuzumab during the dose expansion phase. So Again, it was a multi-center randomized open-label 2-part modular phase 1b/2 study. And in this, as I mentioned earlier, untreated HER2 positive advanced metastatic breast cancer with measurable disease and no previously treated or stable brain mets, and patients who had a more than 12-month disease-free interval from adjuvant anti-HER2 therapy were included. They were randomized to trastuzumab deruxtecan versus trastuzumab deruxtecan with pertuzumab, and the third arm was trastuzumab deruxtecan with durvalumab, which is not presented yet. And just to be clear, the HER2 positive status was either IHC 3 plus or IHC 2 plus, but FISH positive. So our classical HER2 positive. So the baseline characteristics were very well balanced across both arms. If you see, what we need to see out here also is that even hormone receptor positive status patients were well balanced in both arms. So hormone receptor status positive patients were 47 in the TDX arm versus 34 in the TDX with pertuzumab arm. And looking at the recurrent disease status, 27% patients had a recurrent disease, and in 20% had in the trastuzumab deruxtecan with pertuzumab arm. So the overall response rates for trastuzumab deruxtecan monotherapy was around 76% versus 84 with the TDX with pertuzumab. Complete responses were seen in around 8% patients versus 20% in the combination arm. And the median duration of treatment had not yet reached, and 12-month PFS was around 80 versus 89% in the combination arm. If you look at the response rates, were marginally better for trastuzumab deruxtecan with pertuzumab. So the overall response rates in the de novo state, in a de novo subgroup, was 79% for TDX alone, and for the combination it was 86%. The CR rates also were significantly higher. It was almost double. When 2% had a CR in the TDX arm, the combination arm 4% had. And if you see the response rates by the hormone status, the overall response rates were also similar in the with trastuzumab deruxtecan versus trastuzumab deruxtecan with pertuzumab arm. Now, the first thing that would come to our head when you look at this combination, that was it more toxic when you combine TDX with pertuzumab, and also it comes to my mind that will the rates of left ventricular dysfunction be more when we look at this combination? So it was in fact not more at all. It was the 6% patients had some form of LV dysfunction in TDX, and 4% had it in the combination arm. If you look at other adverse events which were seen in more than 20% patients, so grade 3 nausea, which was around grade 3, was seen in 4 patients versus no patients in the TDX pertuzumab arm. Somehow the TDX with pertuzumab arm was well tolerated, better than what we expected to be. So to conclude, in the interim analysis from this study of Destiny Breast 07, TDX monotherapy as well as TDX with pertuzumab both show a good anti-tumor activity in patients who have untreated HER2 positive MBC. They have robust efficacy regardless of disease status or the hormone status. There were few PFS events in both treatments arm, and the treatment ongoing is seen in 62% in TDX versus 56% in the TDX with pertuzumab. Safety profiles were consistent with the known individual profiles, and no ILD or pneumonitis-related deaths were seen. The phase 3 trial, which is the Destiny Breast 09 trial, which is still ongoing, which this will evaluate TDX and TDX plus pertuzumab versus THP in patients with previously untreated HER2 positive MBC. So THP right now is the go-to regimen for most of us in de novo metastatic HER2 positive breast cancer. So somewhere down the line, we would not be using chemotherapy at all and probably going to TDX with pertuzumab. Thank you.
Yeah, thank you very much, Dr. Jehan. It was really very nice and crisp, and you have finished on time. Really appreciate. And there are many questions are being seen, but I think we'll keep the chat on the panel discussion. I now request Dr. Chandrakanta, MB from Kolkata. He's the moderator of the next session, and he will invite his panelists who are Dr. Suman Mittal, Dr. Murtaza Bora, Dr. Amit Agrawal, Dr. Kanchan Gaur, and Dr. Kanjari Medhi. So I think all our the panelists are there on the board. So please go ahead, Dr. Chandrakant. Hello, am I audible?
Yeah. Yes, you're audible.
Yeah.
I'm just.
Yeah, go ahead, Dr. Chandrakant.
So yeah, I think my slides are visible and I'm audible.
Yes, yes.
Okay. So thank you, sir, for that very kind introduction. So I would thank Ashok sir for this opportunity. So we had an exhaustive presentation of I think around 8 randomized trials of ASCO 2024. So we have half an hour to discuss. Like we have some 6 minutes, 7 minutes for each trial. So I will go in the same order as it is there in the agenda. So I will initially present the trial a little bit, and then we can have a discussion and expert comments of each one of you. Anybody can interrupt in between. If anyone has questions, they can freely come on. So it was wonderful listening to both the speakers. Okay. So the first one trial is the iSpy 2.2. So we all have heard of iSpy being a game, and here is the iSpy 2.2 trial. So what is this trial all about? So this is one of the dreams for an oncologist for an early breast cancer not to give chemotherapy. Even in a high risk early breast cancer, it's a dream of an oncologist not to give chemo, and that is what these guys are looking into. So what these guys have done is in the HER2 negative subset. Okay, so they are having a potential combination of Dato DXT versus Durva. So what is this Dato DXT? Dato DXT is nothing but the TROP2 inhibitor. I was just going through what is this TROP2. TROP2 is expressed in a lot of tissues like breast, pancreas, ovarian, prostate. Even sacituzumab govitecan is also a similar TROP2. So therefore, you see these molecules coming in bladder cancer, coming in breast cancer because of the TROP2 expression. So basically, it's a small chemotherapy that is bound to the antibody drug conjugate. So you are basically binding a antibody drug conjugate with immunotherapy, something like a pembro chemo, something like that, Durva with Dato DXT. So this is the basis. And they did have a begonia study where in the metastatic setting, they showed a response rate of 79%. So based on this, they wanted to do a trial in the early breast cancer subset. And you can see some fancy things like a 70 gene assay, immune responsive subtype, and so on. So what they did was they gave 4 cycles. They did an MRI, and the MRI was a class. It's not a usual MRI. It's a 3D MRI. Like they calculated the volume and not just a 2-dimensional image. They looked into the volume of shrinkage. If there was excellent response, they would do surgery. If there is no response, then they would give more chemo, and again they will do MRI. Not only MRI, they will also do a biopsy to make sure that is there a pathological complete response. So this is what the basis is. Can we avoid chemo in early breast cancer? Begonia was the basis, and there is synergism between Dato and Durva. And this is how the pathological complete responses are. If you look into the immune responsive subset, there is a significant pathological complete response. And this is what the conclusions are. If I use Dato DXT plus Durva, pathological complete response in 33% of patients. PCR is highest with immune responsive predictive subtype in the subtype. So 1/3 of patients, maybe we can avoid chemo is what they are saying. So, this is what my take is, like 1/3 of HER2 negative EBC do not need chemo. We need to figure out which are those immune responsive or immune predictive subtype, and they use a 3D MRI in this. So these are some conclusions that you would see in the social media or elsewhere. This is what they're saying. I'm genuinely excited about utilizing the chemo-free regimen. However, selecting the immune responsive subtype is currently impractical in practice. It is worth noting that for only 1/3 of patients, a chemo-free approach suffices, while for the remaining 2/3, both chemo and pembro are administered. To consider our current practice, I would require a randomized trial and access to EFS data. So, Dr. Suman, your comments on the design of the trial, on the combination. So, how do you see this trial?
Trial in initial looks exciting, but probably we do not have any long-term data. So few things we will need, that how to choose those patients where we will be getting the highest response, that is a immune response positive disease, that is the one thing. Plus I think we need long-term data so that we can think of doing a chemo-free regimen in early breast cancer where most of the patients are curable, and we don't want to lose these curable patients in a long term. So probably we'll need better way to know these patients, where will be good response and what will be the long term data. So it looks exciting, but we have to have more data and we have to wait for some time before we can. That is my take.
So great comments, Dr. Suman. I think that is what even the experts have opined. So it is exciting. We are able to avoid chemo in early breast cancer HER2 negative in up to 1/3 of patients. We are nearing to a chemo-free regimen in the early breast cancer. But who are that 1/3? How to pick up the immune responsive subtype? And then what about the remaining 2/3? They end up getting pembro chemo and also pembro with Pacli, pembro with anthracycline. So as you very correctly said, we would need survival data also before we go into, before we change the practice. So I think this is not a practice changing, but there is a ray of hope for early breast cancer to have a chemo-free regimen in near future. And that is what is I-SPY 2.2 all about. Anyone of the panelists have any more comments? They can. Okay. So now let's go to the second trial. This is a BRAVE study. Okay. So BRAVE study is simply after completing all the definitive therapy, you would, in the triple negative breast cancer, you would give. So we have BRAVE for atezolizumab. We have been hearing BRAVE. And here we have BRAVE for avelumab. Can anyone mute those who are not speaking, the organizers? Thank you. So we have BRAVE for atezo, and here we have BRAVE for avelumab. Okay. So, well, this is the design after you have completed, those patients who are at high risk of relapse or there is no pathological complete response after neoadjuvant therapy. And this is the randomization, avelumab versus observation. So, Dr. Murtaza, so your comments on these novel idea and the design of the trial, are you happy with the observation arm?
Sir, still, as we know, we have multiple, still we have option of capecitabine also with the same subset of the patients. So we have to see what is the main difference between the avelumab and this capecitabine. If we are using capecitabine because it's very cheap and we are comfortable of using the side effect profile also. So we have to see what major difference between these two trials for Createx for the capecitabine and the avelumab for this BRAVE. So depending on
fantastic,
this, we have to...
Fantastic. Correct. So Dr. Murtaza, as you very correctly said, the control arm is controlled. Like you are not giving the standard of care in the control arm. You could have given capecitabine if there was no pathological complete response, or you could have given olaparib based on the Olympia. So you haven't given both of them in the observation arm. So therefore, the control arm has not received the standard of care. So with all that, and this is how both the subgroups, they were well balanced. There were significant number of patients with residual disease, and this was also well balanced. And just note this here, adjuvant capecitabine was given, but it was not given in everyone. So that is what you need to do. So it was given, but it was not in 100% patients. So, and olaparib, no. So the control arm is not that optimal. With that nuances in mind, you have a overall survival that is statistically different. You can see 0.66 hazard ratio, but the disease-free survival is not different. So DFS not significant, but OS significant. So these are the investigator conclusions. Just read out the last line. So we know that DFS is, the hazard ratio is modest, and the overall survival, there is a good hazard ratio of 0.66. And just look into the last one. Investigators concluded that avelumab could have a role in treating patients with early TNBC and residual disease after neoadjuvant chemo, or high-risk disease after surgery and adjuvant chemotherapy. So these are some expert comments which I could look into. It is commendable that they have judiciously utilized only at the end of treatment, specifically in cases with a high risk. You would see new immunotherapy just coming in the neoadjuvant, and then they go on for 1 year, irrespective of response. But here they have selected patients who are actually at high risk. That is one. Secondly, avelumab was not used in the NACT setting, therefore it doesn't have any implication on the, it doesn't modify the pathological complete response rate. And thirdly, the extent of benefit derived from this approach is minimal and lacks statistical significance. So it is perplexing to understand that there is OS benefit without a corresponding DFS benefit. So, however, we may consider implementing if you have not given pembro in the NACT setting, but the control arm is undertreated, as you already said. So, not yet practice changing, but if someone has not given pembro, maybe we can use. That is what is the expert comments has been. So, I will go to Dr. Amit. Dr. Amit, your thoughts on the design and on the results and whether it is practice changing or not.
Yes. So one good thing about this trial is they have allowed patients who have gone upfront surgery. I mean, they have not received neoadjuvant
Correct.
and they have high risk disease like T3, T4 or T2N1. So that is one thing, because in India, many a times we get patients who are triple negative but underwent upfront surgery. So in such situation, we give obviously chemotherapy, that is ACEC or taxane plus minus carboplatin, all these things. So in such settings, especially, and obviously they have not done the germline BRCA testing. So if patient is germline BRCA negative, then probably we
they
can
have, but it's, I mean, but it is very less. Like there is some data of germline BRCA.
I mean,
Yeah.
probably they have not allowed olaparib.
Yeah.
So obviously, if a patient is germline BRCA negative and high risk, who has undergone upfront surgery at high risk of relapse, in such patient, we can give this option. Obviously, that perplexing point, why the primary endpoint is not statistically significant, which was DFS, but OS is statistically significant, is one thing, I mean, confusing. But one option we can provide to our patient.
Good. So you would agree with these expert comments that was there in the Twitter? Oh, they're well put, right?
Yes, sir. Yes, sir.
So very true. So I think Dr. Amit made very clear comments. One is this trial is good in that if a patient has underwent surgery upfront, which happens when the patient lands up with a surgeon and he operates in the triple negative and he comes down to you with a high risk disease, where there is no data for adjuvant pembrolizumab or other immunotherapies, but here you have for adjuvant avelumab. There is a niche space where avelumab has got data in adjuvant setting not being used in neoadjuvant. That is one point what Dr. Amit made. Number two, the control arm CAPE was not given in everyone, and olaparib has not been used even if germline BRCA mutated. Number two. And number three, the magnitude of DFS is not that great, and it is not statistically significant to change your practice. And without having a DFS benefit, you have a OS benefit. Again, this is difficult to comprehend. Is it a non-relapse mortality? We need to see the complete data. And maybe in those settings, as Dr. Amit very correctly said, someone has not received neoadjuvant or no IO in the neoadjuvant. In those subset, maybe we can counsel these patients. Is that right, Dr. Amit? I mean, I could summarize what you said.
Yes, sir. Yes, sir.
Perfect. So the first trial, we wanted larger data. The second trial, maybe, but if someone has not received neoadjuvant, again, not that greatly practice changing, maybe I will prefer Pembro. So probably I would prefer Pembro as of now. But if Pembro is not feasible or not given in the neoadjuvant, maybe we can proceed. Okay, now the third one is Oncotype DX, the recurrence score that we see. So we have excellent data of recurrence score in the node negative setting, even in premenopausal. And just remember, just to remind you regarding the cutoffs, less than 10 is low risk, 11 to 25 is intermediate, and more than 25, that is 26 and above, is high risk. And low, there is no role of chemo, high chemo, whereas in the middle subset, again, you will divide it less than 50, more than 50, and accordingly, you will offer treatment. Then what about in node positive disease? Okay. So let me ask next doctor. We have Dr. K.H. Mehdi. So, well, this is the data we have in N1 disease. We do use Oncotype DX. There is some data. For low and intermediate, we may avoid chemo. But the moment it is node positive and premenopausal, there was no role of Oncotype DX. We had to give chemo for all premenopausal N plus disease. So, well, here is a effort to select out those patients in premenopausal setting with N1 disease, but in whom chemo can be avoided. So, Dr. Mehdi, so node positive, let's say N1 disease, do you use these recurrence score in clinical practice? Do we have Dr. Mehdi? No?
We have lost the connection of Dr. Mehdi. So this question can be taken by
So I will move to Dr. Anu Tiwari. Dr. Anu, if you're there.
She has also lost the connection.
Fine. Then I will go back to Dr. Suman. No? Then we have Dr.
Suman is there.
Yeah, Dr. Suman.
Hello, hi. Can you repeat the question, please?
Yeah, ma'am. So I was just asking you, in a N1 disease hormone receptor positive, do you do recurrence score testing like Oncotype DX, Prosigna, or whatever type of recurrence score? Do you do in a node?
Yes. Sometime if patient have comorbidities, and if you wish to avoid chemotherapy in those patient where giving chemotherapy is more risky, then it is always preferred to do this testing. So if we can select few patient who might go without chemotherapy.
Great. So, ma'am, stay tuned. So I'll just go through the slides. So, well, in postmenopausal node positive, we could have used Oncotype DX to avoid, whereas in premenopausal, in node positive, even though, there was no role of Oncotype DX because chemo was benefiting all premenopausal patients. So let me come. So this is the study design. You have chemo followed by ET versus ET alone, and this is how it looked in the premenopausal setting. Okay, premenopausal node positive, there was a clear-cut benefit of chemotherapy. So chemo had to be given. However, the subset analysis found less IDFS benefit in premenopausal women who were more than 50 years of age, and they looked at anti-Mullerian hormone and inhibin B markers for diminished ovarian reserve. Right? So this is how the consort diagram is, and there were some 1,000-odd premenopausal patients, and they found them eligible. And this is how it is. So this is the serum AMH in premenopausal women less than 55 years of age. 21% of premenopausal women had serum AMH in postmenopausal range. Nearly 21% of them had a low serum AMH. And as we already saw, serum AMH levels, correlated with less benefit with chemotherapy with IDFS. And this is how it is. So now, if you have less than 55 years of age and you have a low AMH in N1 disease, you may avoid chemotherapy based on this. So, Dr. Suman, so here we go. The new data is there in node positive premenopausal, N1 disease premenopausal, low AMH, less than 55 years. Will you change your practice based on this? Will you do AMH as another marker to identify who will not benefit from chemotherapy?
Yes, definitely it looks exciting because traditionally we have not been using AMH to define as postmenopausal women, but with this data, definitely, from now onward, other than LH, FSH, and estradiol, maybe this is another marker we will look forward. But my question is, how many patients we do see who are more than 50 years of age in our country who are still having menstruation? I think the data will be very, very less. That is what I see in
It's less than 55 years. Yeah, it's less than 55 years
so
premenopausal.
above 50 years, most of our patients in our country, what I see is like most of them are postmenopausal by the time they are more than 50. But
True.
maybe
So
in few
true.
can be. But what I think the volume of number of the patient where this study might help will be quite low.
True. So, the take from some of the experts and after going through the literature, this is what it is. The study says that in premenopausal N1 disease, age less than 55, low AMH, you can avoid chemotherapy in a low risk disease, right? However, we do not know whether the number of patients and the data is driven by 50 to 55 years or 45 to 50 years or 40 to 45 years, and we need to have a clear breakup. So, but this is the data. And if you have a premenopausal N1 disease, you do a AMH, if it is low, you have evidence to avoid chemotherapy in these patients. So AMH being another marker, Initially, we had low, intermediate, and high. Intermediate, we didn't know what to do, or we didn't know what to do. And then came the clinical risk score that came here, the age and the menopausal status. And now there is one more marker, that is AMH, that has come in the N1 premenopausal subset in whom you may avoid chemotherapy. This is probably practice changing to looking
So,
into this.
Dr. Chandrakant, can we avoid oncotype DX also in subsetting?
So, well, sir, we were not doing oncotype DX for node positive premenopausal.
Yes.
But now here you have the data.
Yeah.
That you can avoid. You do AMH, if it is low, then you can do oncotype. This is one thing where oncotype DX is again coming up in premenopausal node positive subset in low AMH. And this is something that is practice changing.
Yes, because that is too costly also.
It is costly, yeah.
Yeah.
True. So fantastic. And there we go for the Natalie subgroup analysis of stage 2-3 node negative subgroup. So I will go to Dr. Murtaza Bora for this particular presentation. So this is how it was. So in the node, so we know that Natalie is adjuvant ribociclib for 3 years in the high risk subset, but they did include N0 disease. There was a good IDFS benefit at 3 years. And there we go for the N0 disease, stage 2-3 node negative, HR positive, HER2 negative. And N0 was a significant number. And they defined N0 high risk based on multiple factors. One is they should have had a grade 3 disease or a grade 2 with Ki67 of at least 20%, or a oncotype DX recurrence score of more than 26. That is high risk gene expression profiling. So N0 with these three, you could give adjuvant ribociclib. And a significant number of patients did have N0 disease in this, and they did receive chemotherapy in good number of patients. So there we go. You have a IDFS benefit. So the IDFS benefit is modest, like it is there. It is a small difference, but significant. And the distant disease-free survival, there is a difference with the hazard ratio, but you need to keep side effects in mind. And 3-year IDFS hazard ratio is 0.72, crossing unity because of number of patients. And the distant disease-free survival and distant relapse-free survival are also better, again modest, but it is there. So what are the expert comments? Despite being N0, there remains a notable probability of relapse. Although the benefit may be modest, it could still positively impact a considerable number of patients. Therefore, I would contemplate administering adjuvant tribo in cases of high-risk N0 disease. However, I also take into consideration the potential side effects associated with treatment. So, well, Dr. Murtaza, over to you. What is your opinion on adjuvant tribo in N0 patients based on these results?
So first we have to see this why there's a difference between the both this trial. One is for Ramivan and ribociclib. They have given for the 2 years, and with N1 at least one node should be positive. In ribo, it is for 3 years, and the dosing schedule is also slightly different. It's not 600, it's 400. So according to the recurrence scores, like more than 26 they have considered as a high risk. Still they are saying that despite that N0, some patient got relapse. So we have to see the more subset analysis in the future for this trial, why this N0 patient got relapse, and why it's not included N0 in abemaciclib trial. So taking more strong data for using ribo is at least in N0 patients, I think, because it's also having the febrile neutropenia or side effects of ribo, we know, but still using in N0, we have to see the more advanced or more data of, especially in N0 patients.
So very nice comments, Dr. Murtaza. Just to summarize what you said, adjuvant abima versus adjuvant ribo, the inclusion criteria is different. Adjuvant abima includes that creamy high-risk patients who have a very high risk of relapse. Whereas in the Natali, you would see N0 patients also being included, and that's a significant number. And if you look into the magnitude of benefit in the N0, you cannot ignore it, but it is modest. It is not that high. So the only thought that comes to mind is, should I? We should weigh the risk and benefit. The side effect profile and the benefit that the patient gets. There is a small benefit, but it is large number of patients. You're going to add large. So any reduction in recurrence, even in N0, because even N0 with high risk of relapse, you see 22% patients relapsing on a long term, even in an N0 disease. So therefore, there should be a discussion with the patient and have a close watch on the side effects. If a patient is tolerating, maybe you can offer adjuvant ribo for 3 years if the patient fits into N0 high risk of relapse. So be cautious about the side effects and know that the benefit is going to be modest. It is not going to be high. It's not like adjuvant abemaciclib where there is a creamy high risk, where there is an obvious incremental benefit in IDFS and DRFS. But with Natali, the benefit is not that big because the population is little diffuse. Even a low risk patient is included in this. I mean, a low risk, not a low risk, lower risk. So N0, you may offer, I think the expert comment says it all. Okay, so 4 more trials, let's completely go. This is how the destiny journey goes on from destiny 1, 2, 3, 4, 5, 6, 7, 8, 9. And you have more to come in future. So let's focus on the destiny.
Dr. Chandrakant, can I request Dr. Jehan and Sachin also to join your panel discussion? Because
Sure. They can definitely.
Yeah, Dr. Jehan and Dr. Sachin, please join panel discussion.
Yeah, Dr. Jehan, actually presented the data. So like I can ask Dr. Jehan only regarding this trial. So these are the destiny group of trials that you have, and this is how it is: TDXT versus chemo, in the HER2 low or HER2 ultra low subset, right? The primary endpoint being PFS, and we saw from Dr. Jehan himself, he presented what were the endocrine therapies, what were the chemotherapies that were used, and this is the PFS benefit that you have. The HER2 low subset, the responses we saw, there is a benefit, but again, it's statistically significant. So, this is probably the expert comments that you have. There is a benefit in both HER2 low and HER2 ultra low subset. So, to ensure a clear understanding, as Dr. Jehan was presenting, we need to call up the pathologist and ask, am I dealing with HER2 low or HER2 ultra low? Just to say, what is HER2 low? HER2 low is either it is 1 plus or 2 plus fish negative, that is HER2 low. HER2 ultra low is like 1 to 10% of cells with staining. That is what is HER2 ultra low, which we were not reporting at all. So therefore, in the present day, even whether it is a TNBC or HR positive, you have to call up your pathologist and ask, is there any HER2 staining, as Dr. Jehan was mentioning. In HER2 positive MBC, I would contemplate TDXT as a viable option for third line. In TNBC, maybe for second line. I consider HER2 low and HER2 ultra low statuses as clinically relevant, and in these patients, I would utilize TDXT as a treatment approach. So, Dr. Jehan, your comments on these expert comments. You have them? I think they're not listening.
Oh, okay. So
then,
you
then we will request Dr. Amit to comment on this.
Yes, sir. The expert comment which you have written is perfectly fine. I mean, because till date, at least my pathologists are not reporting the ultra low. So maybe in future, this will come as a standard of care, and probably we will give this option, because many of the patient triple negative, we know it is aggressive cancer. We have the chemotherapy and immunotherapy, or the PARP inhibitor, and this will be an addition to it. So this should be practice changing in future.
So very important, as Dr. Amit said, you have a triple negative or HR positive with exhausted treatment, make sure you call up the pathologist and ask whether it is low or ultra low. Ultra low would not have been reported. Low, you should look into the IHC whether it is 1 plus or 2 plus. Okay, post monarchies, post CDK4/6 progression, abemaciclib versus placebo, and there is a significant IDFS difference, right? So, which cannot be ignored. There is good IDFS difference with fulvestrant. If you continue CTK, that is abemaciclib post palbo-ribo progression, majority had palbo-ribo in the first line setting. So, these are some expert comments. Again, I will, after observing progression following treatment with palbo or ribo, so we can consider abemaciclib, irrespective of PIK3C or ESR1. However, in that subset, the benefit was less. In light of maintain trial, there's something called maintain trial also, where ribociclib was used as continuation after progression. So there is some role of ribociclib also as an alternative to abema. And for PIK3CA, you have other options like alpelisib or capivasertib. That also can be considered in that subset. So before making any changes to my practice, I would prefer to have OS benefit that become available. So these are the expert comments that you could get access to. So Dr. Suman, your thoughts on using abemaciclib second line post palbo-ribo progression in first line in metastatic HR positive breast cancer?
I think this can be a very good option when we can give patient chemo-free treatment for some time and it has shown good response. So definitely, I would like to consider this after using palbo or ribo when we have already used. So before going on for chemotherapy. So definitely, I think it has got significant response.
True, ma'am. So your thought is, if there is a PIK3CA mutation positive, then will you use alpelisib or you will use capivasertib?
So it's difficult to comment for me as of now. So I'll be more tempted to go ahead in that case with alpelisib, because we have some data, and we have seen few patients who are responding to that. So maybe to compare, we'll need some head-to-head comparison
Correct.
between these two drugs in this particular setting before I can comment on which I would prefer.
Correct. So perfect comments. We don't have a head-to-head trial. We don't know, but this is what you can keep in mind. So these are, you can use them sequentially, once they progress. That's also fine.
Yeah, I mean, so that becomes, in that case, we'll have three different lines other
True.
than chemo. So
Correct.
one additional way of treating these patients.
And you have HER2 low and HER2 ultra low also sitting in the back bench. Yeah.
Dr.
So
Chandrakant, just want to sorry to interrupt you.
yes,
To
Dr.
add
Mohan.
this comment, as we know, Alplace is slightly toxic drug, and
Correct,
we
correct.
are more comfortable with Ribo, Palbo, and Abima. So if
Correct,
we want to
correct.
change the hormonal partner, like fulvestrant, we are changing, and we know PIK3 is positive, but still, if this data is we will get more data in the future, and it's a strong data, then we can think of using as a sequentially use Abima as in second line along with the fulvestrant. Then in the third line, we can think of if the patient is still progress or after some time, then we can think of using alplacib as we slight compared to, if we compare the toxicity of Abima versus alplacib, alplacib is slightly more toxic. So this is the way we can think of using if we have both PIK3 also positive then in this setting.
Correct. So the reason why I was putting up is the hazard ratio is 0.86. If you have a PIK3CA positive, so that's the reason why I was discussing. But fine, I totally agree. Abhima is
Sir,
better tolerated.
Amit
than,
here, sir. Another point, just I wanted to add.
Yes, Dr.
So
Amit.
if we look at the subgroup analysis, patient who do not had any visceral metastasis, the difference was much more significant.
Yes.
So probably
Correct.
that is the subset we should look
Where you
and aim for.
pick up to give. Yes.
Yes.
Good. Because it's the difference is not much if you have visceral disease. They're going to progress anyways. Correct.
Yes.
Very important point. So if you have someone not progressing rapidly, rapid visceral disease not there, in that patient, maybe you can consider post-monarch. And there is something like maintain also where ribo was used. Just remember that. Then this is a negative trial SASI with again SASI Pembro is something like the first Dato DXT with Durva. This is also a drop 2. That is also a drop 2 with Pembro. In HR positive, they were struggling to get some benefit. SASI got approval in triple negative, but it did not meet the significance. So probably it is not practice changing, and we may avoid discussing this. And still, we need data and larger. There is modest benefit combining SASI with Pembro, even in PDL1 positive. The benefit is there, but it is not statistically significant. Hazard ratio is 0.62. So then we have, so this is what the conclusion from the author is. Addition of Pembro to SASI showed non-significant trend towards PFS. Final PFS and OS will further follow up, and it will be analyzed in future. So let's wait for the long-term data. The last data is combination of TDXT with pertuzumab. So that's great, like first line setting, no chemo, metastatic breast cancer, TDXT with pertuzumab combination. And what it is, what has it shown? You just note this one. The response rate is 84% versus 76% if I use TDXT monotherapy. So if you use TDXT with PER2, the response rates are better. The 12-month PFS is also better. It looks attractive. But of course, toxicity is a concern, and the responses are fantastic. This is something good. In metastatic breast cancer, HER2 positive, you may not see Cleopatra. So this is some take. So you want comparison of TDXT versus Cleopatra, where, I mean, TDXT plus PER2 versus Cleopatra. Then only you would. So one positive thing is TDXT has a better CNS coverage. So Dr. Amit, your final comments on using not Cleopatra, but Destiny 7 as a regimen.
Yes, sir. So again, this trial is also a very complex trial. They have used multiple different HER2 targeted therapy. So it is one of the subset or one of the arms which we are discussing here. So in this, obviously, they have shown benefit, but we know that we need phase 3 data to suggest that it is useful and safe in upfront setting, because we know that ILD is one of the concern with TDXD, and we don't want to lose these precious patients who are anyways gonna live with duration of maybe 5 years or more. So we need phase 3 data, sir, before launching this into clinical practice.
Correct. So very correctly said. This is attractive, you know. We had Cleopatra where you have docetaxel plus pertuzumab plus trastuzumab giving the longest PFS and OS in HER2-positive breast cancer till date. To challenge that, you need to compare whatever regimen against Cleopatra. Pertuzumab plus TDXT. This is a chemo-free regimen. This is fantastic. One good thing is TDXT has excellent CNS coverage, which Cleopatra lacks. So I am not surprised if the head-to-head comparison of TDXT per2 versus Cleopatra Destiny 09 will be the winner. So we want more comparison data. However, if someone is not eligible for DOSI and if someone has baseline brain metastasis in that subset, here is the data for you to use TDXT with pertuzumab. So I think that's about discussing. I think we had some practice changing trials in between, but all are enlightening. I would thank all panelists for your active participation, and I would thank the organizers for this opportunity. Thank you, and over to you.
Thank you very much, Dr. Chandrakant, and thanks all the panelists for having such a wonderful brainstorming about the newer studies in the early stages of breast cancer as well as the advanced stages breast cancer. And now I invite Dr. Satyapal Kataria to give his take-home message. Dr. Kataria, please.
Good evening, sir.
Good
I hope
evening.
I'm audible.
Yeah, you are audible and visible also.
Yeah, thank you, sir. I think we had a wonderful evening today. We all agree. And our presenters, Dr. Sachin Gupta and Dr. Zehan, presented 4 abstracts each about early and late stage breast cancer. We all agree that breast cancer has been one of the success stories for us, literally curative for all early stage breast cancers, and we have made it into a chronic disease that is probably, hopefully, in another 5 years, most of our patients should be living 15 years or 20 years like that, just like diabetes and hypertension. So with this today's take home, I think I would accept that we are trying to make it our all cancer patients to be more molecular driven. And, optimizing, or rather with precision oncology, we are trying to optimize the best treatment available for one particular patient. Second thing we are trying to do is trying to, even for early stage or even late stage, we are possibly trying to make it chemotherapy free in adjuvant setting or in metastatic setting. That is also some success already we are achieving. And finally, I think we have had trials, like we have had a good trial about TDXT plus pertuzumab in hormone receptor positive metastatic disease, and in de novo metastatic disease and in relapse setting, and showed that it's reasonably good response rates and complete response rates. I think times are exciting and we are going to be much, much more successful very soon. I think this is my take-home message, and I will hand it over the mic to Dr. Shyam Agarwal, sir, please.
Thank you. So kind of you. So crisply and nicely you have summarized and given us the message how to go ahead with the early and advanced stage of breast cancer. With this, we conclude, and I thank to the organizers of Masterclass Conference, Conference to Clinic 2024, especially on breast cancer. We thank to Indian Oncology Foundation, Samarth Life Sciences, as well as the Manage Health Foundation, and not without thanking Dr. Ashok Kumar Vaid, the chairman and program chair of this masterclass. And I'm thankful to all the speakers as the panelists, and especially Dr. Kataria. Thank you very much. And of course, the mice idea, Dr. Rajesh, Mr. Rajesh is also there. Yeah. Thank you. Thank you very much. And good night.
Thank you,
Have a good night.
Good night.
Good night.
Bye.
Good night.
Thank you, sir.